Hi everyone, my name's Katie and I'm one of the junior doctors at Nepean Hospital. This presentation that I'll give today is on the acute abdomen. It will look at history taking, examination, investigations and differentials for someone presenting with abdominal pain and should hopefully give you some helpful tips about how to deal with patients who present with abdominal pain to EDs or GPs that you might have to deal with in the next few years when you're a junior doctor. To begin with, what do we mean by the term acute abdomen? So this refers to a rapid onset of severe symptoms that may indicate potentially life-threatening intra-abdominal pathology and such that requires urgent surgical intervention. So some examples of the kind of things that may cause an acute abdomen are bleeding, for example, from a ruptured aortic aneurysm or from an aortic dissection within the abdominal cavity. It could be from a perforated viscus, for example, a perforated gastric ulcer or a perforated diverticulum. It could be from ischemic bowel, from a bowel obstruction, or any kind of inflammation of visceral organs that has caused some kind of localized or generalized peritonitis. So that might be something like appendicitis or cholecystitis. The location of a patient's abdominal pain is one of the most useful tools you have for distinguishing between your differential diagnoses. And just to remind you, it's largely based on the embryological formation of the gastrointestinal tract as to where you might feel pain depending on which organ is involved. So foregut structures from the esophagus to the mid-duodenum, as well as upper GI organs such as the liver, gallbladder, spleen, and pancreas, all refer to the area around the epigastric region as the visceral nerve supply of these regions then refers to the upper dermatomes of the abdomen. The midgut from the mid-duodenum to the proximal 2/3 of the transverse colon tends to create pain in the umbilical region, and the hindgut, so from the distal third of the transverse colon to the proximal half of the anal canal, refers to the pubic region. Inflammation of the visceral peritoneum tends to result in more generalized vague pain in one of those above regions, whereas if inflammation spreads to the parietal peritoneum, which has somatic nerve supply, the pain becomes much more localized. So an example of this is in acute appendicitis, when initially in early appendicitis, people tend to feel that periumbilical pain as just the visceral peritoneum is inflamed. But as the parietal peritoneum becomes more inflamed, the patient can then localize their pain more to the right lower quadrant. These two images show the two ways that you can split up the abdomen into quadrants and regions. And it's very useful for describing where abdominal pain is and for trying to figure out what kind of structures might be underlying those regions and causing pain in those areas. So on the left side, we have the quadrants, really easy, right and left, upper and lower quadrants. And then on the right-hand side, we have the 9 regions. So on both left and right sides at the top, we have the hypochondrium, so under the ribs. And in the middle there, we have the epigastric region. Then moving on to 4 and 6 are our right and left flanks, with 5 being the periumbilical region. And then 7 and 9, we have our iliac regions, right and left. And then in the middle there, 8, we have the suprapubic region. So here, I want you to have a bit of a brainstorm and pause the lecture at this point and draw yourself up either the quadrants or the regions, whichever one you think you're more familiar with, and try and brainstorm as many possible differentials for pain in that region that you can, just based on location. And see how you go, and then I'll show you a simple diagram that I think is quite useful. So it doesn't have everything, but I think I find it quite useful to think in quadrants, and this covers some of the major pathologies that you might want to have a look at. Also on the side, you've got the epigastric and periumbilical region. You should always consider that pain in the upper abdomen can also be caused not just by an abdominal pathology, but sometimes by a pathology in the chest, such as a pneumonia or an MI. So always keep that in mind with your patients. I think one of the difficult things about someone presenting with abdominal pain is just how vast the differentials this can be, and it can feel a bit overwhelming. What I would suggest and what I like to do is to first think through either my quadrants or regions to determine what might be some possible pathologies given the location of the pain, and then to think about what kind of pathology could be happening in some of those organs that could cause that kind of pain. And for that, I like to use a surgical sieve, so some kind of brainstorming tool to think through those differentials. I like vitamin C, D, E, F, but there's heaps of different ones out there, so if you've learnt one, stick with one that you remember. And it can help you to broaden your thought processes and not get too narrowed down in one idea. Always still remember, though, that common things are common and that typical presentations are much more likely to be a common thing than something very rare. This is how I like to do an abdominal pain history. So starting with the history of presenting complaint, use some kind of system that helps you work through the cardinal features, so Socrates or something similar, that will allow you to elicit the site of the pain, the severity, the nature of the pain, time course, any exacerbating or relieving factors, and any associated symptoms. Some of the really important associated symptoms to rule in or out in abdominal pain are nausea and vomiting, any urinary symptoms, any changes in bowel habits, any diarrhea or constipation, and check the frequency of bowel motions in comparison to the person's usual. Any jaundice. You should always screen for any constitutional symptoms that might alert you to a cancer diagnosis, especially if the history is tending towards you being worried about that. So I use the mnemonic ALERT, so that includes anorexia, any loss of weight, energy levels being down, any fevers, so rigorous fevers or night sweats, and then tumour-specific symptoms. So for something gastrointestinal, we might be worried about bleeding in the stools, abdominal pain, jaundice, etc., things like that. And then you want to know if someone's had previous episodes of similar pain. For example, if you have someone who's presenting with cholecystitis, they might have a history of biliary colic of similar pain that's maybe being shorter in nature, but in a similar position with similar features. You want to know about any sick contacts they might have had that would help you rule in or out gastroenteritis, if they've had any recent travel, and if their vaccinations are up to date. And also for surgical patients, it's important to know when their last meal was, as it will help you to plan if they possibly need surgery, how long the patient has been fasting for. Following on from the history of presenting complaint, you should go through the past medical and surgical history. The most important things are to elicit any previous abdominal surgeries and any previous gastroscopies or colonoscopies that the patient might have had. Sometimes they forget this as it's or might not think that they've had a surgery, but it is important to know in your history. You should find out any medications and allergies. Any medication is useful to know about, but things you might be interested in is whether they take NSAIDs, as this is a risk factor for peptic ulcer disease, and also whether they're on any antiplatelets or anticoagulants, as if they need emergent surgery, sometimes this can be a problem and they might need to be reversed. And as always, you should do a social history and a family history. When you're doing an examination of someone presenting with abdominal pain, the first thing you need to do are vital signs. So look at their oxygen saturations, their rest rate, their heart rate, blood pressure, and temperature to help you to see whether the patient is stable or unstable. It's really one of the most important things that you can do. You then move on to your gastrointestinal examination. So do a general exam, see if the patient looks unwell or uncomfortable from the end of the bed. That can be quite a good indicator of whether someone has an acute abdomen or not. You need to look if they have any lines going in or out of them, the appearance of their skin, their body habitus, and other general examination findings that you do in all exams. You then need to move on to a focused exam of their abdomen, and so do a light and deep palpation in all areas of the abdomen. You need to look for percussion tenderness and auscultate for bowel sounds. You should then go through and perform the complete gastrointestinal examination, look at the patient's hands, face, mouth, and their legs, and you should always have a listen to their chest in any patient that's presenting in the ED. Have a quick listen to their heart and lungs. You should then, depending on the patient, perform any kind of extra addits to the gastrointestinal examination. So a PR exam is very important in a patient presenting with changes in bowel habits, or a patient presenting with anemia. You could do a hernia exam, depending on the patient and their presenting complaint, and also a testicular exam is important in males. And then you can do any other relevant examinations of other systems, depending on the history that you might want to rule out a problem with. In terms of investigations, I like to split it up into bedside, bloods, imaging, and then any further pathology testing. So in terms of bedside, there's a few key tests that you can do for any patient really presenting to ED as quick tests. The ones that are relevant to someone with abdominal pain are an ECG, urinalysis, plus a urine beta-HCG in any female of reproductive age presenting with abdominal pain. I'll go into more detail about this later, but it's really important for females with abdominal pain to rule out pregnancy or any complications of it. And then you can do a VBG or an ABG and a BSL, as someone presenting with hypo or hyperglycemia can also have abdominal symptoms. In terms of your bloods, it will be dependent on the patient and their symptoms, but generally we like to do a full blood count, electrolytes as CRP, LFTs, and amylase and lipase in most patients presenting with abdominal pain to the ED. And then other things you might need to do, especially if you think they may need surgery, are coags and a group and hold. If the person's febrile, presenting with features of potential sepsis, then blood cultures are important. And again, like I mentioned, a beta-HCG in females, and you might want to do a more formal serum beta-HCG if you are leaning towards a pregnancy complication as a diagnosis. In terms of imaging, you should do a chest X-ray in most patients presenting to the ED, but it's important to rule out any perforated viscus because you might see air under the diaphragm. You can do an abdominal ultrasound for different presentations, but for some it's particularly useful. It's useful for appendicitis, particularly in younger patients. It's useful for any biliary pathology. You can visualize the gallbladder and the biliary tree most effectively as a quick imaging test with ultrasound. And abdominal CT is also really widely used in adults to look for any kind of abdominal pathology, and it's probably the most frequently ordered test for adults in the ED presenting with abdominal pain. And there's some use for MRI in young or pregnant patients, or when you can't use CT, for example, when someone might be allergic to contrast or have kidney injury, preventing them from using contrast. Abdominal x-rays are not used that frequently. They're not as diagnostically useful as some other imaging modalities. You might see them used in bowel obstruction, and they can show dilated bowel whips and be helpful in that, but people generally tend to order abdominal CTs if they're worried about bowel obstruction. So it's actually not used all that frequently in the ED compared to the other imaging modalities. And then just some other pathology tests you might be doing. If your urinalysis had potentially showed that there might be an infection, you might send off the urine for a culture, as they may have a UTI or pyelonephritis causing their abdominal pain. And then again, any stool cultures could be useful if someone's presented with bowel symptoms, or if you've done a PR and found that they've had bleeding or diarrhea. It's important to remember that you can always start off management for a patient who presents with abdominal pain even while you're working them up. You should always begin with providing them analgesia. They are likely to require something more substantial than simple analgesia if they're presented with an acute abdomen to hospital. So something like endone or subcutaneous or IV morphine might be appropriate to keep their pain controlled. You shouldn't wait until a surgeon can review them to give analgesia. If a patient really has surgical pathology, it won't make a difference whether their pain is controlled as to them being able to figure out the cause. So you should always keep a patient comfortable with analgesia. You should keep them nearby mouth as they may require emergent surgery. IV fluid resuscitation is really important, particularly in patients that are unwell, but is often needed for any patient who presents with abdominal pain and an acute abdomen. And they may have had vomiting or losses through diarrhea. They may not have had a very significant oral intake at all over the last few days while they've been in pain. They might be acutely unwell and dehydrated. They may even be septic, and all these patients will need to have appropriate IV fluids given to them. You should consider IV antibiotics if you think that the cause of their abdominal pain is likely to be inflammation of a visceral organ. And if they're very unwell, then it's likely that they'll need some kind of IV antibiotics. It depends on the hospital that you're working in, but at Nepean, we often use IV augmentin for intra-abdominal pathologies such as appendicitis or cholecystitis. You should always check with your local hospital guidelines about what kind of antibiotics are being used for abdominal causes of inflammation. And you should always continue to monitor their vital signs. So do them on arrival, but continue to do serial vital sign measurement, as this is one of the most important tools that you have for determining how sick a patient is. So just some important things I want you to note is that certain groups of populations you'd likely consider some differentials over others. In children, they don't always have the typical presentations that you would expect for an acute abdomen, and some things you don't see in children at all, whereas there's some pathologies that are quite specific to children. So I won't really cover that too much in this presentation. The main thing that you'll come across with kids that may require surgical intervention or a surgical consult in the ED of adult hospitals would be appendicitis. And you see that largely in kind of primary school and teenage age children. It's rare to see it before, kind of school age. Females of reproductive age, I guess females have other organs in their abdomen that could definitely be a cause of their abdominal pain that's really important to consider. And you should always consider that it could be pregnancy or a complication of pregnancy that is causing the abdominal pain. So for all females of reproductive age who present with abdominal pain, you should do a beta HCG to check that they're not pregnant, as it will really change the direction of where you're going with your continued investigations and which teams you're consulting within a hospital. So yeah, that's the one thing I really want to stress, and is super important, that any female of reproductive age needs to have pregnancy ruled out before you continue on with your further investigations. And in older people, certain things are more likely. So they're more likely to have comorbidities, things like heart disease, AF, more likely to have cancer. So you should just have more concern for things like mesenteric ischemia, which is often caused acutely by someone throwing up a clot from atrial fibrillation, from bowel perforation, from either a diverticulum or from cancer, and more likely to have ruptured AAAs the older that people get. So just consider all these things, and sometimes they might have pain out of proportion to your physical findings with some of these presentations. So you should really take older people with abdominal pain quite seriously. In terms of the acute abdomen, there's some specific features that you might elicit from your history examination investigations that would make you more concerned. And it's important to be aware of these so that you can appropriately triage how urgently things need to be done for this patient. So any kind of derangement in vital signs and fever is something that's concerning, that may indicate some kind of inflammation, sepsis, hemodynamic instability. The fact that the pain is sudden and severe, and then some of your findings on abdominal examination will make you more concerned. So them lying very still or writhing in pain that's not controlled with analgesia, especially opioid analgesia, guarding or rigidity on your abdominal examination, and percussion or rebound tenderness. Pain that is waking people up at night, In terms of associated symptoms like vomiting, bilious vomiting is always a serious sign that there's blockage in the bowel that's causing someone to then vomit contents back up the other way. Any abdominal distension, previous abdominal surgery, if they've had a significant history of previous surgeries that might make them more likely to have a bowel obstruction. Any history of coronary artery disease or atrial fibrillation, that might mean that it could be a more vascular cause of the abdominal pain. And then in terms of your investigations, obviously you're more concerned if you have things like raised inflammatory markers, a drop in hemoglobin, a raise in lactate that's indicating that part of your gut is not having enough blood supply, is inflamed enough that it is going through anaerobic metabolism and producing lactate. And any kind of abdominal pathology on imaging is also, of course, concerning and helps you to kind of differentiate that this person might have something serious going on. One thing that you'll need to do a lot as a junior doctor, especially when you're working in ED, is that once you've worked up a patient, you'll often need to call the relevant team to ask them to come and examine the patient and potentially admit them. And for an abdominal pain that you think is an acute abdomen, this would be contacting a general surgical team or the acute surgical unit. You need to identify the patient with their MRN name and age. And then you need to make the case for why you think the patient's symptoms may mean that they have a surgical abdomen. So present the relevant findings and especially think about the slide that I showed you before about concerning features that may indicate that someone has an acute abdomen. And if any of these are present, really stress this to the person that you're speaking to. You need to explain key parts of the history, not your full history, but just relevant findings, and then again, relevant findings on examination and investigations. You don't need to always have completed imaging before you speak to a surgeon that's on call. You may, if a patient's really sick and unwell and you want them to be involved early and you think they might make decisions without the need of delay from imaging, then you should contact them early. But often when you're just working up patients that you're not completely sure what's going on with, it can be useful to have done something like an abdominal ultrasound or an abdominal CT that could have guided you further towards a potential diagnosis, and that will make it more clear to them if a pathology exists or not. So now I'd like to go through 2 quick case studies just to give you the feel of how you might work up someone with abdominal pain. I think it'll be really useful to kind of pause it along the way as I'm going and presenting each patient. I'd love to do this in a more interactive way, but it's a recorded lecture. So try and pause it as you're going along and think about what you think might be the key differentials and see how your differentials change as we go through the history, examination and investigations of the patient. So this first patient is a 40-year-old female who presented with a 1-day history of right upper quadrant pain. She describes that the pain has been worsening and is constant, doesn't radiate anywhere, but currently it's an 8 out of 10. Some of the other symptoms she's had have been fever, nausea and vomiting. There hasn't been any blood or bile staining of her vomit. She doesn't have any urinary symptoms or changes in bowel habits. She's occasionally had pain in her right upper quadrant, but it's never been as severe as this. It's always subsided within about an hour and has previously been controlled with simple analgesia. She hasn't really found that simple analgesia has worked in this case. She doesn't have any recent history of travel or any sick contacts, and she's up to date in her vaccinations. She has no significant past medical history. She had a cesarean section 4 months ago. She takes ibuprofen occasionally for period pain and headache, but doesn't have any regular medications. She works as an RN. She's currently on maternity leave. She lives with her partner and her 4-month-old daughter. She doesn't have any family history of any gastrointestinal pathology or any bowel cancer. So on examination, her oxygen saturations are normal, 99% on room air. Her respiratory rate is 18, mildly tachycardic with a heart rate of 100, Her blood pressure is normal, 130 on 80, and she's febrile with a temperature of 38.5. She looks uncomfortable. She's tender in the right upper quadrant with a positive Murphy sign. Her abdomen's soft, but she has some involuntary guarding in the right upper quadrant. So even when you distract her, she's still guarding in that area. So I want you to now pause and think about what some possible differential diagnoses might be, considering the history and examination so far, and then I'll present what I would think from this stage in the presentation. So to me, my primary differential diagnoses would be a biliary pathology, of which I think acute cholecystitis is the most likely. This is given the fact that she has right upper quadrant pain. She's had similar pain to this before, which might represent episodes of biliary colic, but these have always been less severe. She has relevant associated symptoms such as fever, nausea, and vomiting. And she also has that positive Murphy sign, which is quite indicative of acute cholecystitis. She seems unwell with it, as she has that guarding in the right upper quadrant and is mildly tachycardic. So it's someone that I think you would want the surgical team to see quite promptly. However, we have only done a history and examination, and it's possible that it could be another pathology. Some other things I would think about would be a gastric ulcer. That's usually pain in the epigastric region, but could be similarly felt in the right upper quadrant to some extent. She also has a history of NSAID use, which seems to be just occasional use, but you can't really be sure, so that's something to consider. Other things that might affect the right upper quadrant would be a pneumonia. The fever is consistent with this, but she doesn't really have any other respiratory symptoms, so it makes it less likely. She could also have a liver pathology like a liver abscess or hepatitis. She doesn't have any particular risk factors for this, but always worth keeping that in mind and might be able to be ruled out by some of your further investigations or imaging. One thing I will mention is again that she's a fertile female. She has a 4-month-old baby, so could definitely be pregnant. Right upper quadrant pain, not usually something we would think about as being a problem in someone's pregnancy or a gynecological related pathology, but it's definitely worth doing a beta HCG anyway, just to rule out that she's not pregnant before we carry on with any further investigations. So yeah, the investigations that you do, she has a normal blood sugar level and a normal ECG. These are simple bedside tests that you can do to rule out things like a complication of diabetes, such as DKA, and a chest pathology or something causing her tachycardia. She has elevated inflammatory markers, a white cell count of 13 and an elevated CRP. Her cholestatic liver enzymes are elevated, so her ALP and GGT. Her beta HCG is negative, so she's very unlikely to be pregnant. Her hemoglobin, lipase, and lactate, which you did, are all within normal range. You've sent off some blood cultures. This is because she was febrile and seemed quite unwell to you, so you're worried about something like cholangitis or a sepsis that's from a biliary source potentially. Her chest X-ray is normal, so it's unlikely that she has a perforated viscus or pneumonia. And then her abdominal ultrasound shows multiple gallstones, pericholecystic fluid, and a sonographic Murphy sign. So this, as you can see, the investigations have helped us to narrow our differential diagnoses, and now I think it would be really appropriate for you to contact the surgical team at this point of view, given your investigations and this quite clear ultrasound that shows you cholecystitis, to ask them to come and see the patient. So for the management of this patient, the things I mentioned earlier, analgesia, IV fluid resuscitation, IV antibiotics, and keeping the patient nearby mouth would all be appropriate. This patient would require a surgical consult where you should identify the patient, summarise some of the concerning features and explain their pain, and then mention any examination, bloods, and imaging that you've done so far and what you've currently done to manage the patient. You should then, the surgeon has then come to see them and they will get an emergency cholecystectomy. So for this patient, I'd like to explain to you how I would present them if I was speaking on the phone to a surgeon asking them to come and see the patient, just to summarise the findings that we did in our workup. And I want you to try for the next case study to do that yourself. And it's always good to practice your presentation of patients and to be able to elicit the features that you think would actually make the surgeon more interested in the patient and think that they have a surgical pathology that's worth them coming to see. So in this case, we identified the patient, didn't give her a name. Let's say her name is Jody. So this is a 40-year-old female named Jody, who's presented with a one-day history of right upper quadrant pain with associated fever, nausea, and vomiting. This is the most severe episode of pain she has had, although she's had previous similar episodes to this in the past. She doesn't have, on examination, she is mildly tachycardic. She is tender in her right upper quadrant with involuntary guarding and has a positive Murphy sign. Her bloods show raised inflammatory markers, an elevated ALP and GGT, and we've done an abdominal ultrasound that shows pericholecystic fluid, thickened gallbladder wall, gallstones in the gallbladder, and a positive sonographic Murphy sign. I think that this patient has acute cholecystitis, and I'm concerned about the patient given the fact that they are tachycardic, that their pain is quite severe, and the findings on ultrasound that are consistent with acute appendicitis. I was hoping that you could come to see the patient. We've started them on IV augmentin and IV fluids. We've given her 5 milligrams of IV morphine, and we're keeping her nil by mouth. Is there anything else that you'd like me to do for the patient in the meantime, or do you have any suggestions? So I think that could be a way that you could, it's not perfect, but a way that you explain to the surgeon that the things that you're worried about and summarize what you've done so far. You don't need to explain all the little details about the person, and just really giving the key information is the most important factor. So moving on to the next patient, we have a 62-year-old male who presents with a 4-day history of left lower quadrant pain. So the pain has been worsening with sudden in onset. It's a sharp pain that's worsened by movement, and it's a 9 out of 10 pain. He's had subjective fevers and chills at home. He's had 2 vomits, and he's had these episodes of dizziness, which made him a bit concerned. So he's presented to hospital. He doesn't have any urinary symptoms or changes in bowel habits. He has a chronic issue with constipation, however, and he usually will pass a bowel motion every 3 to 4 days. His grandson had gastro 1 week ago, but apart from that, he doesn't have any other sick contacts. He hasn't travelled anywhere recently, and he has up-to-date vaccinations. In terms of his medical history, he has coronary artery disease and had an NSTEMI 3 years ago. Since then, has made significant efforts to lose some weight and eat more healthily. He had an appendicectomy at age 20, but hasn't had any previous surgeries. In terms of medications, he takes atorvastatin, labetalol, aspirin, and perindopril, which are all started after his NSTEMI 3 years ago. And he also takes Movicol PRN for when he has episodes of constipation. He works as an electrician and lives with his wife. He smokes 15 cigarettes a day, drinks between 1 to 2 beers a day, and doesn't have any recreational drug use. His father died of bowel cancer at age 70, and there's no other real family history of any gastrointestinal conditions or any bowel cancer. So similarly, we'll examine this patient. His oxygen saturations are good at 98%. He's a little bit tachypneic with a rest rate of 20. His heart rate is 130, so he's tachycardic. His blood pressure is slightly low, 105 on 70, and his temperature is 38. He looks to be in very significant pain, and he's very pale. He has generalized abdominal tenderness that's most severe in the left lower quadrant. And he has general peritonism. So he has a rigid abdomen everywhere. So what are our differentials at this point in time? Again, I'd love you to pause and to have a think about it yourself, but I'll go through what I would think at this point in time. His seems very unwell. The first thing I would consider would be some kind of complication of diverticular disease. I think the most likely thing would be acute diverticulitis, given the fact that he has that left lower quadrant pain, has a history of constipation, and that's where you find the tenderness the most severe tenderness on your examination. It seems like it's complicated diverticulitis, given the fact that he has unstable vital signs. So I would think about things like maybe he has an abscess and he's become septic, or maybe he's perforated that diverticulitis and has purulent or feculent material that's irritating his peritoneum and causing that peritonism. Some other things to think about could be a bowel obstruction. He's had those vomits. Didn't say that they were bilious, but they're not always to begin with. And he could have a large bowel obstruction that's causing him to feel so unwell. Other things could be a bowel cancer that's causing an obstruction or has caused a perforation to his bowel, and he has that family history of bowel cancer and history of constipation that also make it more likely for him. We have to be careful of mesenteric ischemia in a person like him because he has that history of coronary artery disease and has had a previous NSTEMI, so might have AF and might throw off clots, which could cause reduced blood supply to his bowel. The pain isn't going through to the back, but you could always consider a ruptured AAA, especially in a hemodynamically unstable kind of older person with abdominal pain. So there's some of the things I'm thinking about. You might have thought of some more things. There's some examples of what might be causing his pain. In terms of investigations, you do an ECG, which doesn't show any new changes. It shows evidence of a previous NSTEMI. He has very raised inflammatory markers, a white cell count of 15 and a CRP of 200, a lactate of 3 that's a bit elevated. His hemoglobin, lipase, and LFTs are normal. You send off blood cultures. You do a chest X-ray which shows free air under the diaphragm, which is strongly suggestive that you've got some kind of perforated viscus in your abdominal cavity. You do an abdominal CT scan, which shows a perforated diverticular abscess with free gas in the abdominal cavity. So this person has diverticulitis that's caused an abscess, and that abscess is then broken off and is causing some purulent or feculent material to be in this man's abdominal cavity. So this patient needs to be managed with opioid analgesia, IV fluid resuscitation with bolus therapy as he is hemodynamically unstable. He needs IV antibiotics as he's likely septic from this perforated viscus. He needs to be kept nil by mouth and needs to be seen by a surgical team urgently as he will need emergency surgery. Here would be a great time for you to pause it and think about how you might present this patient to the surgical team, and so practice those presentation skills. And in a few seconds, I'll tell you what I would say. So we have a 62-year-old male who's presented with a 4-day history of left lower quadrant pain. He is hemodynamically unstable with his hypotensive, tachycardic, and tachypneic, and the CT scan shows that he has a perforated diverticular abscess causing free gas in his peritoneum. He has a rigid abdomen and with generalized peritonism. We've started him on IV fluids and have given him a bolus of 1 litre of normal saline so far. He's on IV antibiotics and he's been given appropriate analgesia. We're keeping him nil by mouth. Is there anything else that you'd like us to do in the meantime? And if you could please come and see the patient as soon as possible, as we're really worried about him. You don't need to mention all of the details. They might ask you lots more questions, but especially when you've already done the imaging and the patient is really unwell, I think it's appropriate for you to mention those things straight up and to maybe go into more history if you're questioned more. He would undergo an emergency Hartmann's procedure, when the surgical team comes and sees him and organises him for emergency surgery. And that involves resection. If you look at the right-hand diagrams, resection of the rectosigmoid colon and formation of a colostomy, and closure of the anorectal stump. This is needed because that area is so inflamed. You can't create a primary anastomosis between the kind of proximal part of the healthy part of the bowel and the anorectal stump, because there's just too much inflammation in that area. So it can be reversed, but it needs to be done at a later date when healing's happened and the person's recovered from this acute episode. That's usually done months down the track. So those are the two case studies. I hope you found these helpful, and I hope you found this presentation generally helpful. I know that abdominal pain is a really big topic, and I've only really scraped the surface, but I just wanted to give you a few tips that may help you as a junior doctor, especially when you're working in ED or in acute or general surgical terms, to really be able to work up a patient effectively with abdominal pain. If you have any questions, my email is below there, and you're welcome to email me at any time. But thank you very much for listening.